So we're now going to move on to the testing section, testing and diagnosis. And Mel Krashen and Jason Grebley have been leading this group. Jason is not able to join us today from Australia, but Mel will present on behalf of the group. Sorry. And one other quick housekeeping point. When we're lining up to ask questions or make comments, just a request from the videographer is that some people have already been doing it, but stand at the back rather than right behind the microphone. Just the person speaking should be at the mics, because otherwise we're blocking the camera. And I was guilty of that, so sorry, but please do that moving forward. Thanks.
Thanks, Jordan. So Jason has to make sure that his wife delivers and he's there, and so would rather be here. So I don't know. So what, God, that's the allergies in this city. So what Jason had compiled, was a traditional list of the things you think about when you're doing testing. And then I'm supposed to speak on Saturday about screening, and one size does not fit all. And then what I tried to do was to take all of those components and think through it from a testing perspective. So we've had this comment a little earlier about this notion of syndemics and where does that fit in. And my feeling is that I hate the word syndemics, but we have to move to a syndemic-based testing approach. And one of the things you can do by doing that is you're using testing as a modality to reduce health disparities. Because when you listen to what we just chatted about this morning, it is about health disparities. It is these key populations, priority populations, whatever you want to call it. There are people in our society who suffer unnecessarily because of the policies and programs that we have. So what I tried to do was to think through the elements of testing into its simplistic sense and come up with how this should fit into a syndemic structure. And I came up with these 5 points. And so one of them is integrate care engagement with testing. You can unpack that, and you can unpack it, as Lisa says, you can't wait for everything because you'll wait forever and you'll never do any testing. But you should be thinking about the population or community that you're trying to support in planning the testing needs, because if you just test for Hep C and they need HIV or they need syphilis or they need something else, you're doing a lousy job. The second thing is I'm an anal laboratorian. Laboratorians tend to think about these very detailed kinds of things. And fundamentally, what we want to do is recognize that the world is changing because of technology. And you want to streamline the testing process, and we'll talk about that later, to meet the populations that I just spoke of. The notion of fewer visits, comprehensive testing, and engaging people where they're at. The third thing is it's clear that docs, lab people, they're situated in large urban areas. If you want to improve the reach and access, the best way to do that is through task shifting, not only in a therapeutic perspective, but for a testing perspective. And then finally, we ignore this last piece, which is the ability to evaluate the testing impact on outcomes. Ultimately, if you don't do that in one way or another, you then lose the resources. Okay, so that's a long introduction. So this is the first slide where I'm going to go through each of these in a little more detail. So the testing and the care engagement needs to be planned in the context of the population-specific wraparound services. So I think we need to spend tremendous efforts to doing that properly. And then you could argue about these are priority or key populations. You know who they are. Some of them may not be listed. It is a recognition that these populations face a multiplicity of coexisting risks and comorbidities in these syndemics. Therefore, you need to implement systems of integrated care rather than these disease-specific vertical care models. And we struggle between those two things because, yes, we're here because we want Hep C treated. Well, you can cure Hep C up the wazoo, and these people will still die if you don't think about it from a broader public health perspective, and whether that's addictions, unsafe injection. The other thing was the structural components matter, and therefore the drug policy, the health system design, they matter because otherwise you won't get to the populations who need to be gotten to. So this is my best slide that I can use to illustrate a very complex issue. It's an annual adjusted liver and drug-related mortality rates and deaths amongst Hep C positive people in BC, the hepatitis testers cohort in Naveed, thank you. In red, you see tracking from 92 to 2017, actually. And you see these perturbations that lead to deaths. In red, they're deaths from drug-related mortality. And you had a shift in heroin availability in the mid-90s, killing a whole bunch of people. Then you had these blips with polysubstance use. And then you have these harm reduction events where we distributed in 2006 4 million needles, and it stabilizes. And then lo and behold, you have these fentanyl analogs that show up around 2014, 2015. And this is the deaths just in the Hep C positive population. They're diagnosed, let alone the ones who are not diagnosed, let alone the ones who were not tested. And then you have these wonderful DAAs. So first of all, you have an aging population. So you have this green line where these boomers, we were arguing about what's a boomer, and they're getting older. They survived their acquisition risks. And then the interferon-based drugs did nothing, essentially, because they weren't effective, they had limited efficacy. And then look what you see here with these DAAs, fairly rapid onset of the DAA uptake, fairly dramatic bending of the curve. And you need more data to make sure it's reliable. So what I'm saying is that if we focused only on Hep C, if the blueprint only focuses on Hep C, you're going to miss, you're never going to get to the elimination point because you kill these people from overdoses in that population. So if you wanted to streamline the testing process, what I did is I took the literature, and Jason did a great paper, and a whole bunch of literatures come up, and came up with 8 components. Electronic alerts. So in those jurisdictions where you have family practice, electronic alerts can remind people to think about hepatitis C. They work. They've been shown to work in the US. They could work in Canada. Some places have used them. There are improved diagnostics. So there's point-of-care serology, there's point-of-care RNA, core antigens, still a little less sensitive, but that's another mechanism. The notion of having these rapid, high, and low throughput systems allows you to place these technologies in different jurisdictions based on the community need, not the big system need. Test innovation. There's a push for self or home testing. One of the things we have in British Columbia is we have this model where you have get checked online, where you You can get checked online, and you can basically look at your risk factors, and then it'll suggest a bunch of test orders. You go to a clinic, you don't need to see a doc, and the tests get done. That's an interesting model for those jurisdictions who can have access to it and the people who have the capacity to do it. You bypass the doc, get the answer. If you're positive, what's the engagement look like? The other point is that syndemic testing thing, because in that get checked online, you're actually thinking about the syndemic issues, whether it's gonorrhea, HIV, Hep B, etc. There are a number of trials to implement dried blood spots, oral fluid, or blood. Each of these have some pros and cons, depending on the community that need to be reached by them. Algorithm simplification, reflex RNA testing, limiting the amount of tests once you're confirmed as positive. Do you need genotyping as the more pan-genotypic regimens come on board? All of these things can reduce the number of visits and the number of times someone has to be involved. The seventh is test deployment. So the notion of providing onset testing during care is about minimizing those visits, is about a reality that healthcare is episodic. So if people don't show up, you're going to miss that person. And if they do show up and you only test for Hep C when they need HIV, well, that's not the right use of resources either. And then finally, in certain parts of the world, e-health, internet access, texting of results, we can do that. But if we did it better, we would be able to reach people who are not normally reachable. So that's a long thing on item number 2. But I think if you unpacked it, you'd come up with the right strategy. In terms of task shifting, really, if you're going to increase the reach, who you reach, and the access, you need to minimize those visits, and you need to maximize the encounter value. It means that we have to go from our physician and allied healthcare professional structures and figure out how to reach patients better, whether it's online, home tests, peers, nurses, lab staff, pharmacies, clinics. One thing that's very clear is whether you do point of care or centralized testing, if you want to reach vulnerable populations, it needs to be publicly funded. Otherwise, the worried well or the well-to-do get testing, and then you've ignored the populations that we're all fighting over. The access has to be low threshold. The stigma and discrimination needs to be addressed. It's not simple. Point-of-care tests, if you're in a community, you don't want to be outed, what does that look like? How are you going to deliver that? Quality assurance. The typical clinicians don't even think about this, but it's an important piece. And the quality can't be an afterthought, but it needs to be tailored to reaching people and giving them access. So if you look through the literature, quality management system has all of this boring stuff, documentation, standard procedures, quality control samples, external quality assessment. People hate that. But if you want to ensure that a test is valid and the results are reliable and you're providing the service to the person, it's an accountability issue. And then somehow we can still deliver these tests in remote and rural jurisdictions and other jurisdictions by tweaking the system so that you can make sure the test is done by someone who knows what they're doing and trained to read it and trained to engage them into care. So while it's an expected standard in modern laboratory settings, it's harder to implement in these low and middle income countries, and it's particularly difficult for point of care, but it's doable. And we've done some of that in our own province for HIV. And then finally, no matter how the test gets done, some components of those tests have to be evaluated on their outcome. If at some point you don't have an outcome, it's not going to be funded. So how are we going to track the impact of this testing? So can you confirm that the syndemic testing that you're trying to approach, are the needs being met? That needs to be measured. What does that look like? Can you assess the test cost effectiveness? Does it make sense to use a point of care or a blood draw, especially if you're getting tested for multiple things at the same time? Can you assess the service program model? So how do you deliver the test to that remote, rural, or vulnerable population? You need to be measuring the value of the test as that engagement tool to try and reduce health disparities. Test results need to get into a medical record somehow. Care is episodic in our country, in most jurisdictions around the world. So how do you optimize population-specific testing menus? How do you optimize the test frequency? How do you minimize duplication? You have to think about it and then come up with the trade-off. What's the trade-off look like so that you're still reaching your populations? Even with centralized systems like our own, it is difficult without good data integration. And it is particularly difficult for point of care. For a point of care HIV test, I can tell you it's hard to get the true positives and false positives in the numbers. And yet, technology prevails, and I think we can develop data integration solutions that will help us monitor our current and future hepatitis program evaluation. And I think that needs to be part of the thought process. And finally, I'll show you this slide because it's an illustration of what happens when you can take data provincially, integrate it, and show the impact of care. So you're not going to be able to read any of this. Oops, sorry about that. So this is DAA 2014-2017 in British Columbia. And basically, it shows you that if you have no cirrhosis and cure, you do better than if you have no, okay, I won't be able to show it. Okay, so no cirrhosis and cure versus no cirrhosis and treatment failure, you're always worse off if you fail treatment. Same thing if you have cirrhosis and cure versus cirrhosis and treatment failure, you're always worse if you have the virus. So this actually shows that within this span of a few years and treating about 6,500 people, you can already show the impact therapeutically of treatment. And to get them treated, they need to be tested. They need to be diagnosed. And you can bend those curves. And down below, you have essentially more than a decade of poor interferon drugs. But when they got into people, they actually had the same outcomes. And if you actually adjusted for age and underlying mortality, the net impact of cure is the same with the DAAs or the interferon-based therapies, but it's hard to adjust that. So what I'm trying to say in summary is syndemic-based screening testing, and I'm using testing because screening is a complex word because it's a screening program versus a testing program. It's complicated. We can discuss it another time. Should be used to reduce health disparities, that we need to think about integrating the testing with the care engagement, and it'll help you if you're thinking about a micro-elimination strategy. It really can package those things for those specific community groups you want to go after. We need to legitimately streamline the testing process by using different testing approaches to meet the population needs, not the laboratorian's needs, not the system needs. We need to come up with the task shifting models to improve the reach and access to these unique populations. somewhere someone has to think about how do you assure that that test is reliable so you don't screw the population by them having a poor test. And then how do you evaluate the testing impact on outcomes? They'll be different. What does that look like? How do we do that? So there's no targets, but that's what I have for you to think about. So I think it was hard enough to come up with those 5 issues. I think the targets need to be around those issues, which would be what are the syndemic, how do you measure it? But well, let's bring this up as an example. So if we think through what are the tests that certain communities require, and are they getting them? And then make a target around that. And then in terms of streamlining the testing process, I think you want to try and come up with, are you reaching people, and how do you document it? And can you reduce their visits and things like that? And maybe that's a way of doing it, or do they get the result very efficiently? And then for task shifting, I think you could quantify the people who are trained to deliver the service, or you can document more people getting services through unconventional ways. I think from quality assurance, what you can do is come up with some programs where you actually document that X people are trained, this amount of tests were done, this is the yield. And I think that's doable. And then evaluating the testing on outcomes, I think that's thinking through how you could do that for certain high-risk population, and maybe taking a micro-elimination strategy, like how many people in correctional facilities, provincial, federal, get tested, what's the percentage positivity, what's happened over time, do they get reinfected, things like that.
So, thanks a lot for that talk, Mel. Can you share some of your ideas on streamlining the step from screening to linkage to care? Because as we're all aware, there's tests that are done and then they go nowhere, and people spend another 5 or 10 years getting sicker. So, concrete ideas on how to make that work.
So, I think it's about a bunch of different things, and I think we need to be a little more honest about those different things. Clinicians tend to be very disease focused, and communities in general, when you actually talk to them, they're interested in getting all of their needs met. But we don't often hear that. And so I think the way to do this is to try and educate the communities about what's important to them, and then have mechanisms for them to actually avail themselves for the testing. And then I think the way to do that is, if you test by report directly to them. There is that possibility, for example, in BC, to report all the results into My eHealth, which is they could look up their result. That may not work for someone who's disadvantaged, but you could provide other means for them to get the result. And then I think you need to support them through what does that result mean? And where they need wraparound services, they get those wraparound services to engage them into care.
So, I mean, I like the idea of reporting the results directly to the person tested. That still puts the onus on them to try and find a clinic. What are your thoughts about the sites doing the testing automatically sending that information to sites that are funded to provide hepatitis C care? And putting the onus on those sites to then track down those individuals and get them engaged in the workup that they require.
Yeah, I think it's interesting. Some people may not want to be treated. Some people may feel that they're stigmatized. So I think what you need to do is come up with solutions that work for those individuals through working with the community. It's clear that your baby boomer who survived their acquisition risks is not like your person who's actively injecting drugs, who needs a different wraparound service. And so it's about coming up with models, working with the community to come up with models to meet their needs.
Thanks, Mel. I think you've really outlined nicely a lot of the challenges that go into this. So I think probably the next step is actually going to be to develop these specific targets. And I guess one of the ones I'm wondering about is on the diagnosis rate, whether that's a target that we should be trying to at least put some numbers to. We obviously have very variable estimates about what that rate is, and it varies in different populations. And I guess I'm just wondering if you've given any thought to that about how we figure it out and then what are the right, I mean, obviously in theory, we'd like to say everyone who wants to be diagnosed should be diagnosed, but what are realistic numbers and where should we be aiming for with that?
Yeah, I think, one thing I learned from the Stop HIV initiative in British Columbia, you can say, everyone born between 45 and 75 should be screened. Fine. If you don't fund the infrastructure to drive that process,
Nothing happens, yeah.
Nothing happens.
Yeah.
That said, it's clear that curability of Hep C, literature from around the world, people are doing testing. And so I think if you look at Ontario and BC, where I've seen the data, testing is going way up. And so then the question becomes, okay, do you have good programs in place to identify those people who don't show up? How do you identify, using processes to improve reach and access, whether or not we're truly getting to the populations who need to be brought forward? And whether we spend the money more in engaging those populations than worrying about whether or not every baby boomer gets tested.
Yeah, no, I think it's an important question. So I think that's something that's a challenge for this group. The other thing I wanted to just ask about, you sort of touched on it with the point of care testing and how you get those results into how you get the results, period, but whether is just a question around anonymous testing and its role, and whether that's something that I guess some thought around that.
So this Get Checked Online, which is the bane of my existence in BC, which I like actually. So I call it a bane of my existence because it was funded as an initiative. They pay a private laboratory to do the venipuncture, but they never create an allocation for the actual test. So they never paid for the test. We absorb it through our global budget. And because it's an anonymized system, you don't know whether that test reduces downstream testing. You need to integrate that data in order to show that it's an offset. So it's, to me, for those populations that don't need to see a doc, it's a saver of money. But you need to be able to show that it actually reduces not only the process of getting testing, but it actually is cheaper than our current way, which is pretty dumb. So to your point, that's true. And then think about it. We're so anal about the privacy, and we couldn't make an app that works in Canada that reports back a result to a patient. It's stupid. Other parts in the world can do it. Why can't we? And that's a way that you can bring the results back to them, whether it's a venipuncture or a point of care or whatever. And it's just us thinking about how to just be a little more smart about the services we provide. And it's just as useful for the diseases we're talking about as a whole bunch of our normal healthcare needs.
And last question, I won't hog the mic for any longer, is about the quality control that you put in and about reflex testing. And there's always been this big pushback about doing RNA testing on antibody results because you might have some degradation of RNA, but the data are pretty solid that you almost never go from positive to negative. You just have a reduction in the titer or the viral load. And now that really is irrelevant, I would like this group personally to make a strong statement about that and really say that we should be doing HCV RNA testing on any positive antibody result, because otherwise it's a useless test.
So, again, when you're an anal lab person, you think about certain other things. So certain analyzers can carry over results. So that can be a problem. So then you just want to make sure that when you tell someone that they have Hep C, you're precise about it. We did do some analysis to look at that correlation, and for the most part, you're absolutely correct that most people will retain their positivity. A challenge for some of the stuff in BC is some samples take like 5 days to get to us, and those are more prone to degradation, so that's a pain in the ass. I think these things are all solvable, actually. And the other thing is I think that result needs to get into the hands of the person quickly, and then to think about, okay, if you're positive, okay, here's my, to Curtis's point, here's where I can go for the service.
Just a few points related to what Curtis and Jordan started, like especially related to targets. I think there is a WHO target in terms of 90% diagnosis by 2030, but we need to kind of like look into this whole issue of percentage of undiagnosed. And William and other modeling teams have started that work, and I think we should include that as one of the targets within our document to say like, okay, like we need to monitor percentage undiagnosed as a part of surveillance system, because that will tell us like where we are headed and how we are doing in terms of reaching undiagnosed populations. And then coming to the point of linkage with care, I think reflex testing is one of the things, but if after reflex testing, person still needs to get connected to the right care where he or she could get treatment. And that's we need to create that kind of like a system. In certain places in US, Kaiser did a care coordination program where they took initial testing and then ordered, they did reflex testing and then kind of linked individuals to right level of services, because they found that it's cost saving to them. And it reduces number of visits as well as cost and all of these things. So we need to think about more innovative approaches in terms of linkage with care, whether it's directly sending results to specialists, but we need to kind of create a list of providers who are able to treat, expand list of providers in terms of training providers for treatment, and then creating a mechanism from testing to linkage with care, whether it's the care coordination mechanism or whether it's the directly handing over these test results to a provider in the community and then making that provider to follow up with the patient, which I'm not sure whether that will work, but it's a matter of testing some of these methods, especially when we will come to the group of individuals who have not been engaged with care. That's where the issue will come.
Yeah, thanks for that. I'll say that if you're in Kaiser, it means that you have a job and you have insurance. And so that's one thing. And then I think given the therapeutics and addressing the baby boomers who've survived their acquisition risks, that's relatively easy. I think the hardest piece is engaging them into the breadth of care, alcohol reduction, other components that are important to them. What does that actually look like? And then as you point out, okay, for the people who have ongoing acquisition risks or reinfection risks, what does that care suite look like?
Hi, Denise from Canadian Association of Hepatology Nurses. When I look at point number 3 around task shifting to improve the reach and access, I think of rural and remote settings. I think of doing more with the same. And I think of nurses in nurse-led clinics, which brings me back to when I was working 5 years in resource-constrained settings. And the first thing when we were working in rural and remote settings was, I can't do it. Don't just shift the task to me without the training and all the support. And so out of that came a national mentorship program, which is we're not going to shift everything to you, but rather we're going to share. So we're sharing the tasks within the team, that we aren't just taking it over. So just wanted to hear a little bit your thoughts around that and the infrastructure and support.
So the WHO document, which is referenced there, done in 2008, and what it basically says is that, you don't have enough trained professionals, and task shifting doesn't mean that you're giving everybody the same amount of work. Or more work. It's really about thinking about how you engage these populations through the kinds of services they need. We know that peers work in some cases, but sometimes peers in a very remote area, in an Aboriginal setting, for Indigenous setting, may not work because the peer breaks their confidentiality. So we need to come up with a suite of different services that meets their needs, that's going to be true in correctional systems. All of those things need to be thought through as a package for a community-based approach. Marina.
Thanks, Mel. I think it's a really interesting discussion. One, I would support Jordan in the sense I think there does need to be some targets for number diagnosed or undiagnosed. I think undiagnosed is what we're really after, not only for our own purposes, but for who we're trying to influence here, because that's at the end of the day, we'll get buy-in to this if Canada or the Canadian government or the federal partners can say, look, we're doing as well. So if you look at, Polaris Observatory Group, what do they measure as who's on track to elimination? The things they look at are the number of people tested, diagnosed, number of people treated and cured. And so we need to at least have those as our basis. In terms of how do we link diagnosis to treatment, a simple solution could be when you do a test or take a test, you consent to have that test done, and verbally, not necessarily written. Can you not consent to be linked? Can you not ask, okay, well, if you have a positive test, these are the steps we will go through. We will provide you your name and number to a clinic, or provide you with a name or contact you and provide you with a name and resources to go get treatment. If you make the initial agreement up front, then it leaves autonomy to the person being tested to refuse or accept at that point. And already you put in place a mechanism for them to be linked somewhere. And that could be individualized for the setting, so that if you're being tested in a prison, it'll be different from if you're being tested in the community center, if you're being tested in a hospital emergency room. But you have a mechanism to link immediately by saying, yes, I consent, here's my way I want to be reached, through my text number or through my email or through a letter in the mail or through calling my mother or my sister or whatever it is. And we do that for lots of other purposes, and it would be very simple. I think it would be one way we could get around it.
Yeah, I think there's just how do you do it for the suite of people that need it? It's clear that when you think about it, Hep C has been reportable for 2 decades. And so what does reportability mean? Doesn't mean anything. It means someone's tallying up the cases.
But I think I think we shouldn't shy away from the fact that we need to have surveillance. And I mean, we just need to make sure that there's informed testing. But if there's informed testing, that needs, that's reported somewhere, and we need to be able to use that number to monitor what we're doing, because we're spending a lot of money in this area, which might be better spent, as you well mentioned, to the suite of other services people need. I think that we shouldn't shy away from, how do we address that?
This slide took 18 years to create. But it illustrates your point, which is the ability to not only have a test and see what happens to the individual requires us to think about how we would do it in the country. And there are places within the country that can do this kind of stuff, and there are places in the country that may not do this kind of stuff. And I think one of the things we need to be thinking about is, what are the trade-offs? Like, I personally, like you, completely agree that we should have a few jurisdictions in the country that does really good detailed work, including the surveillance like iTrack and other stuff, to understand where's the epidemic going. And then I think we need to be much more lenient and create models of care that can be delivered in remote and rural sites, in Indigenous communities, and correctional facilities, where we're not as detail-oriented about collecting every little piece, but we're able to still deliver the most important support infrastructure, wraparound services for those populations. That, if that's in the blueprint, that fits with that federal framework, and it fits with what provinces are trying to do, and they're struggling like us about how do you allocate those resources properly.
Do you want to go to your last slide again? Because I think in terms of trying to link,
The slide or the picture?
yeah, no, next one. I think, trying to take themes out of this. I have no problem with surveillance and counting and characterizing populations, and it certainly has great value that I think everyone in this room recognizes here. But in terms of a blueprint and selling something here, your first line, syndemic-based testing as a tool to reduce health disparities. I think this is a great catchphrase that can be unpacked, can justify allocation of resources much more broadly than if you're trying to sell purely a testing program, and has multiple measurable outcomes that will undoubtedly be positive. So, and it's not anywhere yet in the framework sort of worded that way. People are talking about how much a test costs and what you're going to do with the test result. So to say that quite apart from what it is that we're testing for, the whole process of setting it up will help us address the social determinants of health, which is another way of saying health disparities, is key. And that's sellable to politicians. It's a message that they will receive and will potentially make them sign checks, which is what this is ultimately all about, to help the people we serve, right?
Thank you, Brian. I agree.
Hi, I'm Jennifer. I'm a community support worker with the Toronto Community Hep C program, and I just have a few comments. In terms of linkage to care, you're always you're talking about, like, we're going to diagnose someone and then we're going to treat someone, and I don't always think that that's necessarily the end game. I think there's value in people just knowing that they're positive, because it might inform the way that they may use differently, and they may not be ready to go to care right away. And I think it's important, like, if we're going to be respecting a person's right to self-determine what they need for themselves, then I think, we need to do that. So I just, so for me, that's a problem, and a lot of people don't come to care right away, but they eventually do come to care, but they changed maybe their practices in the interim, which also does then extend to the community a bit of safety anyways. So,
Agreed.
that's all I have to say.
I'll try and figure out the wording.
Oh, and I have one more thing to say, just because I'm a bit of a smartass. Boo to you for not including people with lived experience in any of this process. So, as a person with lived experience.
I think that was implied, but okay.
There is?
Yeah.
Okay, I apologize then.
There isn't a list of our group in this slide deck, but there is a group.
Okay.
Yeah, and it includes people with.
Because I looked at all the people on the one list and I was like, wow, where's the lived experience here?
So I guess that's an interesting point. Like, they're not identified as a group of people who are looked at and asked about for input, which they clearly are part of the group.
this is such an exciting part of all of this. Thank you for all that work. To come back to the point around notifiable and reportable diseases and how that policy can be a good thing and how it can be a challenging thing as we go forward. So I see it as a good thing and potentially using it as a tool to link people from testing into a care program, not necessarily a treatment program, but a care program. I think there are real strengths that can be used there in terms of asking people. So for example, on the East Coast in at least 2 of our provinces, once there's a new positive that's identified, a new positive screening test identified within the lab, that automatically reflexes to public health. And then the conversation at the moment is what's happening is that automatically reflexes to the care program to offer care to people. So the referral comes from public health. People can then decide to engage or not engage. And that group of people are within the circle of care so that people don't get lost if they want to be found necessarily. So that's a good part of the reportable and notifiable disease process, I think. And I'd like to hear what other people in the community think about this because it's a big deal, because I think it's a really easy solution if people buy into it in some ways. And if all the testing is done in one place, which it can be. And the second part that makes it more challenging is that when you think about task shifting and doing point of care testing and other forms of testing in the community, there are sometimes some really stark and vehement responses from people who follow and track and count things about whether or not they're going to be able to follow and track and count all the bits if we task shift to other people who may not be as closely connected and or we do anonymized testing in a different way. So I think there it becomes sometimes a little bit of a stumbling block to both anonymized and other forms of task shifting that might really increase access to testing. So I'd like, if anyone has any comments on that, I'd like to hear what people in the community think.
Julie Bruno, I'm not from the community, but it's funny because I think the 3 of us has the same comment, which is the word engagement there. And it goes back to 2 things for me. It's first of all, the reflex testing. I understand all the thing about the lab thing, but at the same time in 2018, just to have antibody and have a stuck to the real diagnosis is a bit obsolete, I think. And the other thing is all this notion of the cascade of care, which means that a positive test, the next step is the treatment and the Hep C treatment, and this lag between the competing needs of the people and their overall health issues and needs. This may be where we have to be creative a little bit in thinking of this HCV-specific strategy within the big syndemic approach. And this might be one place where Canada could stand out and try to have some measures that may relate it to stigma and discrimination and how can we factor in preferences and need assessment and priorities of needs for the person affected within our cascade of care. But I don't have the solution, but I think we could bring something to the table that people don't.
So Julie, it's interesting that you brought that up. In BC, the problem with the cascade of care is it's all downstream and partially upstream, and usually stops by how many people have been diagnosed. And we've had discussions about the challenges of what does the cascade of prevention and care mean? How do you capture that, and what does that look like? And that's, I think, to your point, which is the notion that it's not just about the test directing a person into the system. It's about thinking about how you can bring the person into the wraparound services they need. And I think we don't articulate that well, and I will try and see if I can fit that into this concept, because I really do believe that the test is just one of the tools. And we need to fit those tools together properly.
I guess maybe a conversation, especially around like self-determination, like right now, provincially opt-in, opt-out testing, right? So it's basically your choice. So do we want to have conversations around, are we going to change that? Are we going to take that engagement from the person that wants to get tested or doesn't want to get tested? Are we going to remove that self-determination on how you kind of want your healthcare to go in order to, I guess, meet targets that you guys want to meet? And then my other thing is that you want to limit the amount of visits. I'm going to be very honest, that's completely opposite from the job that I do. I'm trying to increase one visit. Do you know what I mean in the provincial setting? Because it's not visits, it's requests. It's request forms that you have to submit within in a jail setting where I have clients that it's taking them 3 months. They want to get tested. They're engaging. They're making those decisions, but they have to wait and wait and wait. Right. So I think in certain conversations that we do need to recognize that it's not even about limiting visits. It's actually how do we increase visits and increase that engagement to the doctors, to the specialists, to getting tested.
So it's interesting when you put these things together, you never think about all of these tiny little, these nuances. And you're correct. Like the notion that I was coming from was you don't need 5 visits to get your result. You could do it in 1. But to your point, you want to meet the person's needs by as many visits as they need to meet their overall needs. Right. So you're correct. I'll try and figure that out. I appreciate it. I think I've taken too much time.
Getting access to the care you need, but it's hard for me to imagine how stretching out the diagnosis of hepatitis C diagnosis would be helpful to someone. So stretching that over 3 or 4 visits, even if they get other health needs addressed at those 3 or 4 visits, still, if it doesn't preclude them having 3 or 4 other visits, just means that they don't, because I think aside from people being lost to care in those 3 or 4 visits, there's also the anxiety about knowing you might or might not have an infection and all the other things that go on with the delays in diagnosis. So I think what Mel was trying to advocate for is really just trying to get the diagnosis made quickly, not necessarily that.
And so this is the thing, like even if I ask to get a testing done, it may take me 6 months to actually get that diagnosis if I'm sitting inside of an institution. And if I keep putting requests in and I keep putting requests in, then to be very honest, depending on the kind of individual you are, I may actually find myself as a bug or somebody that's difficult because I'm trying to engage in accessing my healthcare within a correctional setting. And then you might actually just be ignored or put to the side because you are a pest about wanting to know your statuses around healthcare, right? So I just think that I hear what you're saying, but in an institutional setting, just getting even that one initial visit is super difficult sometimes.
Right, but wouldn't it still be advantageous to get an answer in that one visit? Right, because
that's the point.
Yeah, no, fair enough. I mean, I see the point. Yeah, I don't know. I mean, I understand your. Yeah, okay. Subtle. It's a challenging subtlety.
You need to use the phone. I think, are we over? There's one more question.
I just wanted to ask, are we making recommendations? Because that is a recommendation that could be made, is timely access to Hep C testing and treatment as determined by the prisoner, by the person in prison. Because it's a separate issue, but it's an issue.
Right.
Yeah, but I would just say that we were having this argument about priority populations, not everyone's a priority and things. Timely access should be for everybody who needs it, whether you're in prison, whether you're in a remote community. We're not arguing with that.
No, there's a real barrier.
But this is one where you might want to specifically say it.
The 3 months is not okay.
Yeah. No, I think that's a good point, that the specific delays that happen in prison that are not related to the turnaround time of a test should probably be specifically addressed. And that's something that we could probably put in there pretty simply. Okay. Thank you, Mel. That was great. Good discussion.